Hi everyone. First I would like to take this opportunity to congratulate the organizing committee for arranging such a lovely seminar, and also thanking them personally to invite me to share my experience and some research to the fellow colleagues. It has been second year in the running that I am presenting and being part of IOMC, and it has been a pleasure being a part. Today I'll be focusing on new diagnostic or adjunctive tests which are available in the detection of oral cancer in the early stage. I'll be talking about the definition to start with, then move on to the epidemiology and the global perspective of oral cancer, and giving a view of the risk factors which contribute to oral cancer, as well as moving on to the main core of my presentation, which is new diagnostic methods which are available. So to start with, how do you define oral cancer, or what is oral cancer? Oral cancer is a malignant disease which can occur in any part of the mouth, that include the tongue, the lips, and the buccal mucosa. But we need to be very careful in defining oral cancer from other cancers which occur in the posterior part of the oral cavity but does not come under the definition of oral cancer. For example, if a cancer occurs in the oropharynx or the tonsillar area, that would not be termed as oral cancer rather than oropharyngeal cancer or tonsillar cancer. So one needs to be very specific and clear in mind what oral cancer means. Giving a global perspective, it is the 6th most common cancer in the world. However, having said that, in some countries, mostly the developing countries, it is ranked number 1 among men and number 3rd among women. And also, there's a wide geographic variation, again as a result of certain risk habits which are used by people in different parts of the world. Fortunately, we know the risk factors, they are well known and established, but even with the most advancement in the science and also the well-established risk factors, the 5-year survival rate is still 50%, meaning that a person who gets an oral cancer, out of 100, 50 of them would die within a span of 5 years, and that's very alarming. In this diagram, you can see the global map, and the areas which are marked red are the ones which have high prevalence and incidence of oral cancer. Just to give you an idea, certain parts of Asia, mostly subcontinent, including India, Pakistan, Sri Lanka, and Bangladesh, have the highest or one of the highest incidence and prevalence of oral cancer among the whole world. Not very common among the European countries, but certain parts of Europe, including France, and in England as well, due to immigration of people from subcontinent, bringing with them their risk habits. Also common in Brazil and neighboring countries, not because of the known risk factors, but there has been research or studies going on which have contributed the high prevalence of oral cancer to a specific habit which is very common among that part of the world, and it's called mate drinking, which is a very hot drink which they use or consume as social mean or regularly. Again, in this diagram you can see the incidence of oral cancer globally, and if you focus the countries, which mainly in subcontinent countries, India, Pakistan and Sri Lanka have the highest incidence. Unfortunately, South Karachi, which is a big city in Pakistan, has the highest incidence of oral cancer in the whole world, and then other parts which include India and other subcontinent countries. So, keeping the global perspective of oral cancer in mind, one should like to know that why is that there is a wide geographic variation, and what is the reason behind, so who are at risk. I personally divide the risk factors into 4 categories. The one which are established, well researched over the years, and there have been strong evidence to support their role in the carcinogenesis of oral cancer. And then we have strongly suggestive, possible and speculative. We all know that tobacco, whether smoked or consumed in the form of smokeless tobacco, causes oral cancer, and that has been established very well with studies over so many years. Alcohol, another known risk factor, causes oral cancer, and then we have betel quid or areca nut, which contributes to main bulk of oral cancer among the subcontinent countries. There have been mixed evidence about role of viruses, especially human papilloma virus, in recent years, and its association to oropharyngeal cancer. However, indirect association of HPV to oral cancer is yet to be established. But having said that, there have been a few reports coming out which have shown some evidence of association of HPV with oral cancer. A few years back, there was a big debate about the content of alcohol in mouthwashes and their role as a carcinogen agent. However, a recent WHO working group have ruled out that alcohol in mouthwashes can be a contributing factor causing oral cancer. So this just gives you an overview of the risk factors which we are aware of and which are under research to confirm their association with oral cancer. And just to give you an example, there are so many types of tobacco consumed all over the world, both in the form of smoked or smokeless. Whichever part of the world you go, there is one or other type of tobacco consumed by the people. Recently, however, in certain part of the world, another form of tobacco consumption has become popular, and more importantly, become popular among the younger people, and that is what called shisha. This is a water pipe tobacco smoking. It used to be a common habit among certain part of the world years back, but recently it has been adapted or modernized, and as a result become very popular among younger generation. And so what they do, they just sit in together in groups and then just smoke this for hours. And few studies, although there hasn't been much research done on this, but few studies have shown that one session or 1 hour session of this shisha smoking is equivalent to smoking 60 to 100 cigarettes. So one can imagine what damage it can do to the oral mucosa and contribute to the oral cancer. The International Agency for Research on Cancer, which is an international authority which gives confirmation of an agent to be carcinogenic or not, has a few years back established betel quid or areca nut to be a carcinogenic and causing oral cancer. And again, this is consumed in different forms. Sometimes if you go to subcontinent countries, it is consumed in a combination with other elements and is commonly called as pan, whereas in other parts of Asian countries it is consumed differently. But overall, it has been established now that this does cause oral cancer. And then it has become more modernized, like other tobacco consumption things. You can see these more and more available in the market in manufactured forms, which is easily accessible and reachable and quite cheap, which again contribute to their heavy consumption by the people, and as a result in high incidence of oral cancer. So these, we know that tobacco, betel quid, alcohol, they just damage the teeth. We all are aware of that. And one can appreciate in this picture, you can see the teeth is quietly bad. But keeping that in mind, this is what is more of our concern, cause of oral cancer. If a person is consuming tobacco, alcohol, or betel quid, and if his or her teeth are worn out, they can be restored or repaired. But once a person with these risk habits developed an oral cancer, like I said in the previous slide, the 5-year survival rate is only 50% with all the advancement in the science and knowledge of the risk factor. One can appreciate, or one can imagine the outcome of that patient as a result of that. So it's very important not only to look at the dental problems in relation to these elements, but more so looking at the overall health hazard of these elements to the patients who consume them. Fortunately, oral cancer, or for that matter any cancer, does not develop overnight. There is a series of stages which happen over a period of time where there is continuous exposure of carcinogenic agents, and irritation by these agents result in the formation of cancer. And this gives us an opportunity to detect or to stop the disease process in the early stage. And these are the different pre-cancer or early cancer signs which we should be able to identify. Any white or red patch in the oral cavity, or any ulcer which does not heal for 2 weeks after removing any known cause, is something which one should be worried about. And these are the things which we worried about, because if these are left undetected or undiagnosed or untreated, they would end up in really bad problem for the patient. So how do we diagnose oral cancer? The current gold standard is, wherever you suspect a lesion to be precancerous or cancerous, is to take a small tissue which is called biopsy and send it to the lab for histopathology analysis. And it has been said over and over again and being established by research as well that occasional sample tissue that turn out to be benign is better than not to do a biopsy to establish a definitive diagnosis. So meaning that it is always good to take a biopsy whenever you are in doubt rather than not to do it. But even just before biopsy, there's one step earlier which is very important and very helpful in most of the cases, and that is to do a proper systematic oral examination. And that you can see in this diagram, it hardly takes 3 to 5 minutes, but it's very important because by doing so, one would be able to identify most of the oral lesions which might be precancerous or any pathology which is present in the oral cavity. Because mind it, oral cancer in the early stages most of the time is asymptomatic. So it might be that the white patch or red patch is being there for so many years unknown to the patient, and if a proper systematic oral examination is not done, it would be unknown to the dentist or the health professional as well. And by the time it develops into something big or becomes symptomatic, the disease has gone to a phase where it is untreatable, and as a consequence the prognosis is quite poor. So biopsy is important, but before that, if we do unless we do a proper oral systematic examination, we won't be able to identify any lesion, and unless and until we identify an oral lesion, we won't be able to perform a biopsy. In this diagram, you can see the flow chart, what happens if a patient has a suspicious lesion in the oral cavity or an ulcer which has been present there for more than 2 weeks. It goes to a routine checkup or an emergency checkup to a dentist, and if a dentist performs a proper oral systematic examination, or if a dentist is well skilled and well trained, he would be able to identify that lesion and perform a biopsy. But at times, one is not confident enough whether to do a biopsy on a certain lesion or not, or one misses a lesion and therefore won't be able to do a biopsy. And that is where the role of adjunctive test, which for me I won't call them diagnostic tests, because since now, till now, it hasn't been established that they can be a certain diagnostic tools, but certainly it has been established that they do help in the diagnosis and therefore are called adjunctive tools. And in the following slides, I'm going to give you an outline of few diagnostic or adjunctive tools which are present and currently used all over the world, more popular in America and Canada and Europe, and are commonly used by dentists, general dentists, to do an oral cavity screening just to rule out any suspicious lesions which are present in the oral cavity. So we can divide them into 3 categories. The first being light-based detection systems, in which we have autofluorescence, and the device is called Veliscope, and chemiluminescence, and the device is called Visalite. And then we have the vital tissue staining, and we use toluene blue for that. And more recently, we have brush biopsy, which has been adapted for oral cavity, and we can do DNA ploidy analysis on that. So in the following slides, I'm going to discuss each individual test in more detail, giving you some clinical pictures and examples how they work. So moving on to the first test, which is autofluorescence. It has been known that there are certain molecules which are present in the tissue called biofluorophores, which become fluorescent when excited by ultraviolet or visible radiation of certain wavelength. And these biofluorophores or molecules are present both within the cells and as well as in the tissue matrix. And this is the device which works on this principle. And the principle is that the device emits a blue excitation light within the range of 400 to 460 nanometers. And when this blue light is shined on the oral mucosa, the normal mucosa with the normal distribution of biofluorophores would become fluorescent and emits a bright apple green fluorescence light, whereas in the presence of any pathology or cancer process, there is disruption in the distribution of these biofluorophores, and as a result, these biofluorophores do not get excited or become fluorescent, and in that area there is loss of fluorescence, and that area becomes darker in comparison to the normal apple green fluorescent area, which is normal. And in this you can see this is a normal fluorescence, a normal tissue under well scope showing normal green fluorescence. In certain cases where there is bacteria or infection or fungus present, increased fluorescence has been observed, but this is the thing which we are more concerned about, loss of fluorescence, which suggests that there is some pathology or abnormal tissue present which causes disruption in the distribution of biofluorophores, and as a result you get this dark loss of fluorescence area in comparison to the surrounding normal fluorescent area. So this is the device which, like I said earlier, commonly used in certain part of the world and becoming more and more popular. And you can see in this clinical picture, although one with good clinical skills can appreciate that there might be some lesion present there, but at times a general dentist would miss it. But when you run a screening test with Veliscope, you can appreciate a distinct loss of fluorescent area, and in this case it was biopsied later and found out to be carcinoma in situ. Another example, an ulcer in the sulcus area at the retromolar part, one might miss this doing an oral examination, but with the Veliscope you can clearly see a distinct dark loss of fluorescent area, and again this was biopsied and found out to be severe dysplastic. These are cases from the research which we did, which I'll show you the results later. Moving on to the second test, which is called chemiluminescence, and this runs on the principle of emission of light as a result of a chemical reaction. It has been adapted recently for oral cavity examination. However, it has been used for so many years for cervical examination and found out to be very effective. And based on that principle, the company adapted it to be used in the oral cavity. So how it works, it comes in form of a handheld tube with a flexible voil which contains two chemicals, salicylic acid and hydrogen peroxide. And when that voil is flexed, these two chemicals are mixed and result in a white bright light. Then that light is used to examine the oral cavity. And what happens, the normal mucosa or epithelium tend to absorb this light and appears normal, whereas there is any abnormal epithelium present, it tends to reflect the illumination, as a result appearing more brighter, and the term is, which is being coined, is called acetowhitening. And in this case, in this pictures, you can see a white lesion present on the alveolar ridge. When examined with Visilite, becomes more prominent and brighter and gives you more clear margins. Here again, with the naked eye, you might appreciate this area, but when you examine it with the visual light, you can see it is much wider and broader. Again, over here, a whiter area which has become more apparent and visible with the use of visual light. And this is just to give an example. This is a normal mucosa with no aceto whitening of any area, and therefore termed as normal mucosa. The third test, which is now commonly used, is called toluidine blue. It is not a new test. It has been in use for more than 40 years. However, recently more advancement has been employed in the use of this test. It works on the principle that this dye, which is toluidine blue, tends to bind to the acidic tissue components such as sulfate, phosphate, and carboxylate radicals, and therefore stain the DNA and RNA. And we know for a fact that whenever there is a cancer process going on, there is rapid multiplication of the cells, and that tissue and those cells have higher content of DNA compared to the normal tissue. So this dye has a tendency to selectively bind to cancer tissue where there is a high content of DNA. In previous years, it used to come in the form of oral rinse, where a patient used to take some amount of toluidine blue liquid in the mouth and swirl it all over the mouth and then spit it back, and the areas which bind to toluidine blue would be visible and therefore biopsied. However, one drawback with this technique was this dye unfortunately had a tendency to bind to the dorsal surface of the tongue without any abnormal epithelium or precancerous lesion being present or not. Recently, the company has adapted or modified the application procedure, and now it comes in the form of swab, where you selectively apply the dye to a certain part in the oral cavity and thereafter wash it away with 1% acetic acid solution, and again coming in the form of a swab. And if the dye binds to the area, that gives you an indication that there is some precancerous process going on, and you take a biopsy afterwards. And again, in this pictures, you can see there's a white lesion clearly visible, and when toluidine blue is applied, it tends to bind to that, again on the palate and the floor of the mouth. And this, like I said earlier, this dye has a tendency to bind to the tongue even though it's normal. And here you can see certain parts, especially the dorsal surface, tends to get stained with the dye, although there was no abnormality in this case, and this was a normal case. So in the next couple of slides, I'll give you some clinical cases where we applied these three tests and the result which we have found. This is a 45-year-old male who came to our clinic with a white patch on the right lateral border of the tongue. The white patch has been there for 5 years. He had 2 biopsies done previously with no dysplasia, nothing, no cancer, no precancer, but still the lesion was persistent. This patient was a heavy smoker, used to smoke 30 to 35 cigarettes a day for almost 20 years. We advised and encouraged him again and again to quit smoking, which he did in a couple of times, but again was unable to continue, was unable to keep the habit away, and continued it again. We did a biopsy. In this case, with the help of the adjunctive tools available to us, and we found it to be severe dysplasia, although keep in mind it was never dysplastic before he had 2 biopsies. And this is the help which we got we use the Veliscope, the autofluorescence device, and if you go back to the previous slide, you can see the white patch is quite white on the right lateral border of the tongue. But when we use the Veliscope, we found that the whole white patch didn't show loss of fluorescence, only a few areas where loss of fluorescence was found. And again, that area showed aceto-whitening with the use of Visilite. And on top, when we applied the toluene blue retained or stained the same area which showed loss of fluorescence. And that helped us in selecting the biopsy site. And we did the biopsy from the same site which was shown positive by all the 3 tests. And that's a site, and that's how we found out to be severe dysplastic. So, giving you an example that although if a lesion is visible, these diagnostic or adjunctive tools do help in selecting a biopsy site which might be useful for the diagnosis and the treatment of the patient. Another clinical case, a red area in the retromolar part of the oral cavity. We performed the Veliscope and it showed a clear, distinct loss of fluorescence, and then we applied toluene blue and it also binds to the area. Although clinically it is not very clear or visible, and we did a biopsy later on and we found it to be carcinoma in situ in this case. Again, in this case you can see that these devices did help us in the diagnosis. Me and my group, we did a series of studies looking at the diagnostic accuracy of all the 3 tests, the Veliscope, the Visilite, and the toluene blue. We selected around 150 cases in which we ran all the 3 tests, and we did a biopsy to confirm the histopathology analysis. But we found out that the sensitivity of all the 3 tests were on a higher side. That is, the ability of them to detect any abnormal lesion in the oral cavity was quite high. But when we look at the specificity, which is their ability to differentiate dysplasia or precancerous lesion from non-dysplasia and non-cancerous lesion, the toluene blue showed higher specificity compared to autofluorescence and chemiluminescence. So what does this mean? This means that although these devices or these tools have the ability to give some information about the precancerous status of the lesions, they should not be taken as definitive diagnostic tools and should only be used as additional or adjunctive tools wherever you feel like you're not confident enough or not sure about whether this is a precancerous lesion or not, and also where you're not sure which area to select for the biopsy, and these tools have found to be effective in that regards. So just coming to the end part of my presentation, we know that oral cancer is one of the most life-threatening of all conditions. Not only because it is fatal to the patient, but also because even if the prognosis is good, it is cosmetically deforming. The first choice of treatment in oral cancer, like most of the cancer, is surgery, and one would imagine if a patient has got a lesion on the tongue or the buccal mucosa or the alveolar ridge, if that part is removed, that would be cosmetically deforming as well as functionally impairing to the quality of life. And those 2 factors would contribute to the psychological disturbance of the patient as well as the whole family. So we, as dentists, as healthcare professionals, should take ownership for policies related to control of oral cancer, since we know the risk factors, they are well established, and if we counter those, and make policies to counter those, this disease can be fought against. Few years back, a research was carried out among the general public in UK, and it was shocking to know that almost around 50% of the people of the general public were not aware of cancer happening in the oral cavity. I'm talking about a Western developed country, 50% not being aware. And on top, although 76% of these people do identify smoking to be associated with oral cancer, only 13% said that they consider alcohol to be a causative agent for oral cancer. And again, more shockingly or more alarmingly, although 50% said that they think that oral cancer is a disease of chance and can happen to anyone regardless of risk factors being present or not. So one can imagine what could be the situation if we translate this to less developed or developing countries. That would be more scary. So how do we fight against oral cancer? There are a number of methods or screening methods which are available, but all of them have pros and cons. But for most of the researchers or clinicians, an opportunistic screening is the one which has the most cost-effective and beneficial effect to the patient. And that is, whenever a patient or a person comes for a normal dental checkup or for a normal checkup, a health checkup, one should take that opportunity to do a normal or complete oral systematic examination, and mostly targeting the high-risk groups, the groups which smoke, consume alcohol, and use basal pipe. And there has been evidence in the literature showing that the periodic screening of the oral cancer not only identify new lesions which might be cancer or precancer, but also reduces the mortality in high-risk groups. And this is one example where, in this case, this patient came to us in July 2008 with a widespread white lesion on the lateral border of the tongue, again a heavy smoker. We advised him to quit smoking, and good of this patient that he quit smoking, and we can see a change or betterment of the lesion within just a 2 years' time, and that would have great consequence for the overall quality of life of the patient. So just to suggest how to fight against oral cancer, initially or in the beginning we need to define our protocols. We need to target the high-risk groups. Knowing the risk factors, we can always do a periodic systematic oral examination using these adjunctive tools to further help in identifying any lesions in the early stages, and also giving them advice and help wherever needed to quit these risk habits. It's very important to target early detection. Like I said in one of the diagrams, that oral cancer does not happen overnight. There is a long series of stages which happen before a tissue becomes cancerous, and that gives us an opportunity to detect it in the early stages. And there have been cases reported where detection in the early stages have good prognosis for the patient. For the last few years in the UK, we have this mouth cancer awareness program which happens in November of the year, And during this, there's a massive advertisement both in the print and electronic media as well as in the hospitals, seminars arranged, knowledge-based conferences and talks arranged, group meetings arranged for the patient, and targeting high-risk groups specifically and general public particularly, just to giving them knowledge about the risk factors which causes oral cancer, and also giving them a guideline or a path where if they develop a certain precancerous condition, they can be looked after or treated properly. And we have found there would be a few studies which would be published maybe later this year or next year, where we have seen quite remarkable improvement in the outcome of this campaign. So just to end my talk, as a take-home message, we know that oral cancer is a lethal disease and is becoming more and more common. The male to female gender ratio was 1:1, 1:2, but now it's coming close to 1:1, changing in the lifestyle, change in the use of these risk habits, becoming more and more commercially available. But we also know that it can be prevented. This is one of the most preventable cancer among all the cancers. We know the risk factors, and if we remove the cause, tobacco, alcohol, and which are the main causes, we can reduce 70 to 80% of the disease. And we also know that if detected early, they are easier to treat and prognosis is good. Therefore, proper oral cavity screening for both precancerous and cancerous lesion makes sense. With this, I end my talk. Thank you very much.
Thank you very much, Dr. Kamran, for your very interesting and informative presentation. I would now open the floor for any question and comment from our audience and experts. If you have any question, you can just simply type the question in the chat box, or alternatively, you can raise your hand using the icon provided in the software so that your microphone can be unmuted. Dr. Kamran, just for your information, 2 questions have already been posted for you in the chat box, so if you can possibly read out the questions and then answer them one by one, I would really appreciate that.
Okay. The first question, which is does consuming alcohol in general causes oral cancer, or is it only the excessive consumption which will lead to oral cancer? Very good question. Yes, it has been shown that excessive consumption of alcohol causes oral cancer. However, if consumed within limits, which is a national guideline for alcohol consumption, it does not cause oral cancer. But having said that, there are certain well-established carcinogenic elements present in the alcohol, and again, different body reacts differently to these elements. But you're right in saying that excessive consumption is the one which we are more worried about, but if consumed within limits, it is okay. The second question is fact or a myth? Britishers' oral dental health is worse compared to Americans. If a fact, why? If a myth, disregard the question, please. Well, there are certain reasons behind assuming that the British oral dental health is worse compared to Americans. I don't have the statistics to report, but I know for a fact that there is not much difference. There used to be years back or decade back, but now the oral dental status of Britishers is improving day by day. So, but frankly speaking, I won't be able to give you a certain figure where I can clearly say how much is the difference between Americans and Britishers. think those are the two questions which have been posted so far.
Yeah, thank you very much, Dr. Kamran, once again for your presentation, for the very interesting and insightful